Okay.
Okay, good afternoon, everyone. Thank you for joining our second EHE office hours meetings where we'll be discussing the social determinants of health. My name is Zoe Sasser. I'm an associate on the Health Systems Integration team at NASTAD, and this webinar will be co-facilitated by Allison Heinrich, a senior manager on the Health Systems Integration team at NASTAD. Looks like we'll probably be a smaller group today, but that's great because we'll be able to have a great group discussion this afternoon later in the meeting. Sarah, why don't we go to the next slide? So just a quick disclaimer, this project is supported by HRSA as part of a cooperative agreement and does not necessarily reflect their views. Next slide. So here's our agenda for this meeting. First, we'll do a quick icebreaker, then you'll hear about NASTAD and the SCIP, then we'll talk about HIV and the social determinants of health, and then we'll hear from our guest speaker, Sarah Magnuson with King County. After that, we'll have a group discussion, and please be prepared to share how the social determinants of health impacts your community. And then we'll ask you to complete a quick evaluation and then finally wrap up. Next slide. So just some quick housekeeping. This session is being recorded and we will share the recording and slides with you all after the meeting. We ask that you please stay muted while presenters are speaking. And this is an interactive meeting, so please drop any questions or comments in the chat and raise your hand so we can hear from you during our discussion portion of the meeting. We know that Zoom fatigue is real. So you're welcome to stretch or step away for a minute in order to stay focused. And finally, we ask that you please complete the feedback survey at the end as it helps us improve our meetings. Next slide, please. So now we're gonna jump into our icebreaker and let some people in as well. So we're gonna do a this or that, and I'll read out the prompt, and all you have to do is write in the chat which option you prefer. So the first one is work from home or the office. Ooh, depends, hybrid. Okay. Work from home. Okay. Next one is movies or book. Books. Oh, movies. Okay. Hybrid. I need the socialization. Okay. I agree with that. We're fully remote, but it would be nice to see some other people sometimes. Um, Next one is grant writing or field work. Field work, grant writing, field work. Okay. Early bird or night owl? Early bird, night owl. Okay. I'd say I'm an early bird too. Um, Night owl. Data analysis or strategic planning?
Oh, strategic planning.
I think I heard somebody say strategic planning. Great. And then, oh, data analysis. Okay, we have a pretty good in between. And finally, city life or country life. Depends on the mood. Suburbia. Okay, she got it. Mix of city and country. Great. Thank you guys for participating in that small and quick little icebreaker. It's nice to get people kind of chatting in the chat. So Sarah, we can move on to the next slide, please. So some background on NASTAD, if you aren't familiar with us. NASTAD is a nonpartisan, nonprofit association that represents public health officials who administer HIV and hepatitis programs in the US. We serve governmental public health agencies across states, territories, and local jurisdictions, and we do this work by strengthening governmental public health through advocacy, capacity building, and social justice. Next slide. And here are the friendly faces of the team, so please feel free to reach out to us at any time with questions or TA needs. Next slide. So the EHE SCIP, or Systems Coordination Provision Team, provides technical assistance on the integration of healthcare services. Here are some examples of the TA we provide, including leadership development, learning collaboratives, communities of practice, and peer-to-peer learning. Our areas of TA expertise are listed on the bottom, which include data sharing and integration, program policies and procedures, procurement, subrecipient monitoring, and program evaluation, developing innovative programming for key populations, and stakeholder and systems level engagement. Next slide, please. So today we're going to be talking about the social determinants of health. And according to the CDC, the social determinants of health are the non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age. And these conditions include a wide set of forces and systems that shape daily life, such as economic policies and systems, development agendas, social norms, social policies, and political systems. Next slide, please. So the social determinants of health are grouped into 5 domains: economic stability, education, access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. And it's also important to note that the social determinants of health have been shown to have a greater influence on health than either genetic factors or access to healthcare services. Next slide, please. So how does the social determinants of health impact the HIV care cascade? Research shows that people with unstable housing have a 16% lower viral suppression rate compared to those with stable housing. People with mental illness have a lower viral suppression rate on average by 8.5%. People who inject drugs make up 1 in 10 new HIV diagnoses, and people ages 13 to 24 make up 21% of new HIV diagnoses, while people ages 50 and older make up 17% of new diagnoses in the US. So next slide, please. Now I'm just going to ask, in your opinion, which social determinants of health has the most impact on HIV outcomes? And feel free to put it in the chat. Okay, I'm seeing unstable housing, yeah, housing, instability, education, housing. Yeah, great. And Sarah, can we move on to the next one, please? Transportation needs. Yeah, absolutely. And this question is, if you could collaborate with any organization to address social determinants of health of HIV, who would it be? And built environment as well. Yeah, thank you. Yeah, community-based organizations, local Department of Health, yeah. Social media influencers, interesting. Okay. Ryan White parts in the States, all Ryan White parts in the States. Housing providers, church, faith-based organizations, that's huge, yeah. Social media influencers, I like that. I'm gonna note that. That was not one I was thinking of, but interesting. Housing programs and another faith-based religious. Great. Thank you guys for putting your answers in the chat. Housing programs. Okay, sorry. Sarah, we can move on to the next slide, please. So it's crucial to collaborate and partner with various organizations that address social determinants of health when serving people living with or at risk of HIV. And listed on the slide are some examples of strategies and types of collaborations to do this, such as partnering with agencies that provide housing support, education, and employment agencies, local law enforcement, transportation agencies, food banks, and food assistance programs, and more. And addressing social determinants of health is essential to achieving equity in HIV outcomes. The goal is not only to improve individual outcomes, but to shift systemic barriers that perpetuate health disparities, ensuring long-term sustainable impact. And we can go to the next slide. Additionally, there are strategies we can implement inside our own organizations and teams, such as providing staff training and development, opportunities to enhance health equity, incorporate responsibilities related to addressing social determinants of health into position descriptions and performance evaluations, and using robust data systems that can be shared across your organization that include metrics and data around social determinants of health. And in order to effectively address social determinants of health in your communities, it's essential to engage various planning bodies and community groups to learn directly from the community what it is that they need. And we can go to the next slide where I'm now going to pass it on to our guest speaker, Sarah Magnuson with King County. Sarah, thank you.
Hi, thanks, Zoe. Hi, everyone. I'm Sarah Magnuson. I work with Public Health Seattle King County. I am the EHE Community Partnerships Coordinator, and she, her pronouns. We can go 2 slides, actually. So today I'm going to give like a really brief and high-level background of what King County looks like in terms of our HIV rates, and then dive into 2 specific activities that we've implemented through ending the HIV epidemic. So in King County, we have almost 2.3 million residents, and we are the most populous county in Washington and 13th most populous in the United States. Our existing HIV systems have worked really well for people with HIV. We achieved the UNAIDS 90-90-90 goals a few years ago, even pre-EHE. But we still have about 7,200 prevalent cases of HIV in 2022, about 200 estimated undiagnosed folks. And among all of this, there's really glaring disparities, specifically among those undiagnosed and out of care. So with EHE, we really are hoping to reach this last 10% of the folks who we haven't been able to reach with existing resources. So that's really what we focused all of our EHE funds, both with HRSA and CDC. So if you go to the next slide. And kind of who that 10% is really largely persons who are living unhoused or unstably housed and or have severe mental health or substance use disorders. And it's a lot of folks who are living in South King County, which is south of Seattle. So less in this kind of central core where we have historically seen the most HIV diagnoses. And as kind of predicted across like a lot of the United States, we see disparities among Latinx MSM and US born Black MSM, additionally in African born populations. So among the 49 activities that we've implemented in the first phase of EHE, I'm highlighting two, which are really the expansion of our low barrier services and our ED collaborative, our emergency department collaborative. Next slide. So first we'll dive into the low barrier services. Next slide. And next slide, because I have a lot of like in between slides. So the Max Clinic, which if you haven't heard of it, I'm not going to go into a lot of the history of it, but it was developed in 2015, and really it stands for maximum support. It was developed by our Part B clinic and Public Health Seattle King County in 2015 to really address the needs of folks who have complex medical and social needs and are not well engaged in HIV care in a traditional sense. And really I think the quote that really sums it up is, what can we do to make things easier or better for you? And that's really how all of the Max team addresses people's needs and care. So to expand the Max Clinic, EHE added funds to add an additional nurse and a mental health provider. The nurse really allowed for more, the nurse and additional MD time allowed for morning hours, because traditionally we've just had afternoon hours. And the mental health provider is all walk-in services. So it's kind of single session, intensive, addressing needs as like of the day, less kind of a long-term engagement just based on the population that we see. And since expanding, we've seen nearly double the amount of patients who have received medical care daily, which is really exciting. Next slide. Oh, next slide. These are just the buckets of what is provided at Max, and I'm not going to go into these. I think the slides will be sent out afterwards and you can dive in. Again, there's a lot of publications and presentations on Max Clinic, so I'm giving kind of the high level here. But if you go to the next slide, the kind of who is seen at Max, the majority of Max clients are experiencing housing instability, use substances, and or have psychiatric diagnoses. And 42% have all three of these factors. Next slide. And yet we've had really great success. So we see pretty high rates of viral suppression, even though this is a large, like a pretty challenging population. And as of 2024, we have surpassed 300 unique active clients. So we've seen more than that, of course, over time, but this is the highest level of active clients that we've seen at Max. Next slide. So next in our kind of timeline of how we expanded low barrier services is the Aurora and SHE clinics. Next slide. So this was a pre-existing partnership with Harborview Medical Center, who runs our Part B clinic, and Aurora Commons, which they had developed a partnership to open the SHE clinic in 2018. And SHE was really implemented to meet the needs of female identifying folks who live and work in North Seattle and largely are exchanging sex, inject drugs, and or experience unstable housing or homelessness. And it's really focused on trauma-informed practices and providing safe space for female identifying folks. And while we were implementing our developing our EHE plan in 2018, there was a HIV outbreak in North Seattle, which really kind of informed how we developed an expansion to this Aurora clinic, which is essentially the same model as SHE, but open to all folks. So any, not just female identifying, so any folks could enter. Next slide. And the services provided here, so all of the, well, that's not true. So the services provided here are status neutral, so you don't have to have HIV to seek services here, all walk-in based. And we use CDC and HRSA funds braided to kind of provide holistic care for anyone who walks in. So we provide HIV prevention, STI prevention and care, and just kind of primary care light. Mental health and substance use medications are on site. The mental health is kind of newer up north, but it's just getting started and has been really great. And again, everything is extremely trauma informed and really provides a safe space for anyone who walks in. Next slide. This is a very busy slide, but this is really just showing the total clients seen. We've seen 429 folks from 2023 to 2024, 15 of whom have HIV. And then specifically this year, we've already seen 347 clients, 15 of whom have HIV. Next slide. And the successes here really are the collaboration between the two teams. I think they have daily huddles before and after each clinic, which really gets everyone on the same team. So like folks who work at the Commons, which is a drop-in center for people who are experiencing homelessness, are meeting with the clinic staff to really like collaborate and ensure all the needs of these clients are being met. So like housing connections, reaching folks, and like getting specialty services addressed. It's been really beautiful to see this collaboration. And the teams up north have been relatively stable. They haven't had a lot of turnover on either side, like the CBO side or the clinical side. And I think just a highlight of a specific patient success story is they have someone who's been clinically or like a client who's been virally suppressed for over a year and initiated an HCV treatment, hepatitis C treatment, and they were able to get him into housing. And this is a client who's been visiting the Commons for many years and has been not virally suppressed the entire time. So it's just been very cool to see this initiation and care. Some of the challenges are really addressing mental health services with this population. It's kind of similar to Max, but a little bit different because it's much more of a drop-in and folks are there. So sometimes they want more ongoing mental health services, but we don't really have capacity for that. And then pharmacy is really a big barrier to all of our new low barrier clinics because there's no kind of pharmacy storage on site. So everything has to be couriered in and out. And I think another challenge is really they're just providing so much more primary care that's not specific to HIV, just based on the population. And I'll share a little bit more of the low barrier care data later. So if you go to the next slide. So next in implementation was expanding our MOD clinic, next slide, which is our moderate assistant. So it's kind of in between a traditional Part B clinic and the maximum support clinic. So it provides walk-in services for both treatment and prevention for HIV. And really what we did here is we provided patient navigation services and again, mental health support there. And I'm actually going to kind of breeze through this and not go through all of these data because I think they're very similar to what you would expect. So if we go to the next slide. Some of the successes at this clinic have really been the low barrier nature of the mental health model has worked really well for this population. The mental health provider has maxed out their caseload and did really quickly. So we see kind of a potential for expansion of more mental health services. And similarly, the patient coordinator has really been able to both engage and re-engage quite a few people with HIV and get them back into care, which has been really great. And we see that it really frees up some time for the medical case managers, which is also great because they definitely are very overburdened in our clinics. Some of the challenges is there's a consistent community, like a backlog of patients who need behavioral health services. And we're kind of dealing with this community referral requirement for folks who are on Medicaid. So you are required to refer to outside community or any community mental health provider. But our workaround is we're seeing them for mental health services in between. And a lot of the times, you know, there's a backlog for mental health services, I think nationwide. So folks are waiting like 6 months to a year to get in with another provider. Yeah, next slide. And then the last to implement for our low barrier services were our Engage Health clinics, which are in South King County. Next slide. And these are extremely similar to the Aurora Clinic model. All the same services are offered, the braided funding to provide status neutral or whole person care services. But this was a new partnership with Harborview Medical Center and Catholic Community Services. And the clinics were really built out in day centers that are already serving these unhoused populations. And they're in Federal Way and Kent, which again are both in South King County. CCS on the kind of CBO side was originally providing housing case management. And then we kind of reorganized because they were able to provide those services through other funds. And now they are providing kind of outreach and engagement coordinators. Next slide. So again, they've already, or from 2023 to 2024 grant year, they saw 361 clients, 47 of whom have HIV. And then this year, they've already seen almost 250 clients, 37 of whom have HIV. Next slide. I think this is a repeat. Next slide. Some of the successes down there are they are working really well as a clinical team. They're providing, they're very nimble and efficient. Kind of a challenge because they're nimble and efficient, or they have to be nimble and efficient because there's been an immense amount of turnover down south. And I think this is really largely because of kind of the nature of South King County. There's turnover we see across all of the organizations who provide care in South King County. And I think it's just because it's much more of a clinical and service desert. So I think because of that, the burden on all of the staff has been exceptionally high. But they're working really well to outreach to folks and respond to urgent medical needs, and really increasing connections with other local CBOs and organizations who work with these populations. They're doing a lot of direct outreach and kind of engaging folks in the day centers as they come in to kind of usher them in for medical services as well. And they are seeing a lot more people with HIV down in the South clinics than they are up at the Aurora clinic. And I think that's both because we're seeing a lot more diagnoses and people who are out of care who are migrating south. And I think they're also getting a lot more referrals from our neighboring county in Pierce County. So Federal Way specifically is like 5 miles from Pierce County. And Pierce County's gone through a lot of changes in terms of their HIV care landscape. Other challenges. So I think because of the staff turnover, they've had to change hours quite a bit. And I think that's been pretty challenging. And, the nature of a low barrier clinic is walking in and receiving services. But if the hours are changing, I think they're losing a little bit of trust with the population because they don't know when they're open. And it's hard to, navigate if you're closed on Tuesday this week, but open next week. I think that's really hard for the population. And similar to up north, they really see a need for general primary care services rather than HIV specific, or primary care funding rather than HIV specific funding. Go to the next slide. So this is looking at Aurora and Engage viral suppression. So in the red, we see Aurora Clinic has extremely high viral suppression, higher than the Max Clinic. I will note, again, the number of people with HIV at Aurora is a lot lower. But overall, I think it's really exciting to see how high the viral suppression rates are for this population who is unhoused, has mental health disorders, substance use disorders, and really is the hardest to reach population. But we see once they're engaged in care that works for them, we're really seeing exceptional results. Next slide. So now shifting gears quite a bit, another activity that we implemented through EHE was the EHE Emergency Department Collaborative. Next slide. And really the kind of reasoning behind putting together a group of emergency department providers was all roads lead to the emergency department. And we know that the ED sees folks who don't seek services or healthcare anywhere else, and the ED is their primary source of healthcare. So it really provides a unique ability to provide screening and linkage to care while you have a captive audience. And I think like providing patients with knowledge of their HIV status is really incredible. And I think it really had the potential to work really well because if there's anyone that tests positive in King County, public health follows up with them. So I think a lot of the hesitance for doing kind of blanket screening, opt in or opt out in the emergency department is like the follow up. But because public health DIS are really good at their jobs, I think it provides a little bit of a safety net for providers to know that they don't have to be the ones to follow up and link them back into care. And there is a lot of literature on other jurisdictions and cities who have done this. I think if you're interested in learning more about opt-out screening in the ED, Highland Hospital in California and kind of the larger Alameda County has been really incredible in implementing this. Next slide. So our emergency department collaborative began with about 11 organizations and 14 unique emergency departments. And when we began, there were about 1.2% of all people who walked in the ED who were tested for HIV. And at our highest, we bumped that up to 3.1. So that's still really low, but I think we do see that there is this increase. And really, like, the emergency department collaborative goals are and have always been extremely simple. It's just to increase HIV testing, but specifically screening, so non-diagnostic testing in the ED. And to get these data, we really collect 3 data points from each of our ED participants every month, and that's it. I think like it's a pretty low impact, what am I trying to say? Low stakes. You don't have to do a lot to be involved. Next slide. So involvement does look like one-on-one meetings with our physician champion. So we have one physician who we pay like 5% of his time, who really provides a lot of the structure and support and connection to all of the ED providers. And so he meets with all the EDs one-on-one, and then we have quarterly meetings. I say or monthly on this slide because we've kind of changed as time's gone on. So this has been going for about 3 years, and participation has waned quite a bit. So I think we've kind of tried to change the structure regularly to see what works well for people. Right now, we are on a quarterly 1-hour call with all of the ED providers invited, and then one-on-one check-ins as needed or as requested from the providers. And again, we collect the 3 data points. We've done some poster campaigns to put up in the waiting rooms for EDs to really kind of both raise awareness for clients and serve as reminders for providers to draw blood or for anyone who they're drawing blood, add the test. And another kind of in trying to gain more participation and awareness of it, we have always we've distributed awards for the sites who have seen the most progress in increasing screening. Next slide. So again, we have seen some progress in increasing screening in the ED, but I think the biggest challenges with this activity are this has been extremely dependent on the physician champions who are engaged with us. There has not been a single site who has been able to automate, like through their EMR, adding the HIV test. And I think this is pretty detrimental to progress. So like, for example, the site who got the award for the most increase in screening, I think went from around 1% to about 7%. But it's a really small ED, and it just was like based on inspiring all of the providers to increase screening. And when there was turnover, those numbers plummeted again because like it just required constant education and motivation. So next slide. While there was a lot of initial excitement with the champions from the ED Collaborative, I think progress has been a little stale. And I think like some progress has been made that is lasting, like our UW system. I will say the ED Collaborative provider who runs the collaborative also works at UW. So I think because he's the most motivated, we see the most consistent success and lasting success there. But I think like other sites have seen some lasting success, which is really exciting. I think another kind of cool thing that came out of the collaborative, and this is true of a lot of our EHE activities, is there was this natural request from folks who attended the meetings to bring in a more syndemic lens. So we brought in a lot more education and expertise around hepatitis C and syphilis testing, and even kind of have been encouraging if anyone is thinking about like EMR updates and automating these test requests, like implementing all three of these instead of just HIV. I think a lot of the challenges for the ED Collaborative, COVID-19, I mean, we started this ED Collaborative in 2020, so bad time to really work with EDs. They were overburdened, as we all know. And I think even past the initial like 2020 surge, each surge really pushed back like any progress we had made, because as we all know, the emergency departments were so overburdened because of COVID. And I think that really led to a lot of burnout. We saw a lot of turnover from our physician champions. And then I think it's been harder to identify new champions when folks like leave their organization. We've had success in some sites, but not all. And I think like the biggest challenge is really not being able to implement at a systemic level. So next slide. So we are really trying to kind of think about the ED Collaborative as still having these really committed and dedicated providers, but also we've been doing a lot of kind of top-down outreach and engagement. So really trying to work with hospital administrators to convince them that implementing EMR changes is necessary. But we'll see. That just kind of started this year, so we haven't seen any tangible changes yet, but we're hoping that by all of us and the physician champions being really loud and advocating for this need, we'll see some change. Next slide. And that's it. So I would love to answer any questions that folks have. I know that was a lot of information really quickly.
Thank you so much, Sarah. I just first have to say, like, the work you were doing in Seattle and King County is so impressive, especially considering, you know, the start of EHE was during COVID, so there were significant challenges, certainly. I have a couple of questions myself, but I don't want to take up all the time, so I'm going to pause and see if anyone in our group has any questions. Feel free to come off of mute, or you can type it in the chat. Or if folks are still thinking, I will start. So going back to your low barrier clinics, I love that you really invested your EHE dollars to reach that 10% that you talked about that wasn't currently being engaged in services. Because that's really what EHE is for, right? We know Ryan White works really well, but for those who are in it, not for those who we can't keep in it. So I'm curious to know, with that 10%, did you already know who those individuals were? Did you already have that sense, or did you have to do any outreach, education? And then, you know, how were you able to actually engage them in those services?
Yeah, I think, I mean, we knew kind of at the epi level who they were. And I think for folks who are out of care, we know who they were. But for folks who are undiagnosed, of course, we don't know them until they are diagnosed. But I think the collaborations with like CBOs and clinical providers was really crucial for the ORAC and the Aurora and Engage clinics, because they're already engaging with this population at kind of the broad level. So they are working specifically with folks who like are experiencing housing instability and are unhoused. And all, I would say, like 75 to 90%, depending on the clinical population, of folks who go into these day centers and drop-in centers have substance use disorders or mental health disorders. So we know they are folks who aren't seeking services like any healthcare services in general. So providing low barrier services for anything, I think, was really crucial. And I think it's been successful, like being able to reach over 50 people through these clinics. It's, 50 people isn't that many people, but when we have really great success with our Part B program and all of our other HIV resources, it is impactful here. But yeah, I do think like having those CBOs who are already working with the population was really crucial.
I absolutely agree with that. 50, I would say it's not a small number. Every person counts. That gets us closer to our goal, and that's really amazing. Going back to your emergency department program you were doing, how did you identify your physician champions? Did you already have that relationship established? Did you have to go out and recruit others? What was that process like?
Sure. So a little bit of both. So as I said, we pay for time for an emergency department like facilitator or not supervisor, but yeah, facilitator. And the person who was originally in that role is extremely well connected with local and national emergency department groups and had been a participant in a previous collaborative or group that was really focused on hepatitis C, but had kind of petered out over time. So I think that he was really able to do a lot of individual, and he also like ran the residency program. So I think had a lot of like specific personal connections in all of the EDs, just from providing training for all these folks. So he was really crucial in both knowing who was already interested, who had provided, or who was interested in hepatitis C, which a lot of folks, like there's a lot of crossover in HIV and hepatitis C interest. So I think having that champion was really crucial to kind of identify folks who had already engaged in similar activities and outreach to other EDs and other providers who might be interested.
Thank you. Are there any questions from anyone in the group? All right, well, if any questions do come up later, definitely feel free to put it in the chat, or Sarah was kind enough to include her contact information here. We will be sending out these slides and recordings. You all will have access to that. But thank you so much, Sarah, for that wonderful presentation. Can we go on to the next slide, please? And the next. All right, so now we are to my personal favorite time of this meeting, where we get to hear from you all and have some great group discussion and hear, about the successes and challenges going on in your jurisdictions and have some time for peer-to-peer learning. So since this webinar's theme is around social determinants of health, that's what our questions are centered around, but we'd love to hear from you all. What are the main social determinants of health that have had the most impact on linkage to care, re-engaging in care, and achieving viral suppression in your jurisdiction? What strategies can be used to make social determinants of health support a standard component of HIV services and programming? Are there any systems level changes that would strengthen your ability to address social determinants of health? But also, what are some of the barriers to addressing social determinants of your health? What's kind of keeping that away from you all? You don't necessarily have to answer all four. I know these are some pretty heavy questions, so definitely take some time and But we would love to hear from you all if you want to turn your camera on or come off of mute, or you could even type it in the chat. But would really love to hear what's going on in your jurisdiction, have some time to learn from each other. Oh, I see Jonathan came on camera. Did you want to say anything?
Oh, I guess sure. I think so. One of the things that we I'm from Mecklenburg County, Charlotte, North Carolina, Mecklenburg County. And we are looking to, or have been in the process for the last a year and a half, to actually streamline our linkage to care services to where it looks like across our whole jurisdiction. So as opposed to it looking differently from organization to organization, from health department to organization, we're collaborating with anybody that does linkage to care in any capacity in the area to build one linkage to care initiative where it looks the same across the board. And we're able to kind of talk to each other about linkage and what clients are, have a system in place, a digital system in place to where we're able to track those linkages real time at the same time. Obviously, the organizations won't have each other's access to that system, but the health department, which is why I work at, will be able to look at that across organizations and see exactly where we are with each particular client. And then from a numbers perspective, you know, how each agency is doing in regards to retaining and or linking individuals, whether they're newly diagnosed or in out of care. The other good thing that came out of this system is that because the health department is pretty much streamlining and assigning these cases out to the organizations as it relates to the linkage and finding these individuals, is that we've been able to um get a list from our state system, NCX. And utilizing the system, we identified all of the people that are out of care or look like they're out of care in our jurisdiction. And we're able to get those cases assigned out with the help of our, like I said, the Linkage Care Initiative, and assign them out to those agencies alongside the Linkage to Care team that works in the health department to find those individuals and reengage those back individuals as well. And again, track real time of what the outcome is with that client and how long it takes to get those people back reengaged. So just kind of really actually streamlining what linkage care look like and making it look like, you know, making it look collaborative and the same across the board is pretty much what we've been also geared to do. Also, one of the things is that as far as the challenges has been is that we realized is that because in the past linkage to care has looked so differently across organizations, that the training may not be the same and what components are and most important to each organization may not be the same. And so we've had the opportunity to kind of work with some technical assistants to build out trainings for all, whether that's Part A and EHE, for all of our jurisdiction or all of our subrecipients that receive funding in any capacity, to be able to participate in those trainings. Some of them, a lot of them are required now, especially if you are a subrecipient of the county. So that again, we have some good touching points on how to re-engage individuals back into care, and just help with the strength-based approach and on how they're doing it. So that's pretty much how we've been able to kind of get around and working on some of the challenges that we've seen since we were trying to bring it all together on the skill sets of each organization.
Thank you so much for sharing with us. I love that, being able to really, like you said, streamline it and make things consistent across agency to agency, and also really investing in your workforce. I think that's great. Is there anyone else who would like to share? Usually people love to talk about the barriers. What barriers to social determinants of health have you seen in your jurisdiction? What is getting in the way of addressing housing or transportation, education, all those items you listed in the chat at the beginning of this call? I know a lot of people mention housing. Is it a lack of affordable housing? Is it the availability of housing assistance programs? Having enough housing partners? Oh, yes, I hear someone. Go ahead.
Sorry, it's okay. So I think there's uh it is housing. So I'm in Columbus. And actually I think we'll probably be chatting soon at some point. This is but we do have housing programs, and I think, we've got a couple status neutral programs that have been really beneficial and helpful, but it's still not by any means really putting a significant for a better word, dent kind of in the need, for, you know, cost of living compared to cost of living needs compared to, average income don't match up at all. Um, Income requirements for most other programs, requirements set forth kind of for like what clients need to do in order to access services is a huge barrier and sometimes just not realistic, right? You're talking, you know, asking clients that are in crisis to hold a certain kind of job for a certain amount of time, to have a certain kind of income, or to only have income that produces a W-2, to put it kind of that way, is a barrier to a lot of these programs to access them. Engagement requirements, the requirement to be engaged in case management and reach certain goals in a specified timeline that just aren't always realistic, and often just not always, it's just that they're typically not realistic. And so then clients aren't eligible for services or lose services because they're exited from programs, which kind of then restarts their process, right? And in some systems, so for example, this is outside of like the city of Columbus. This is the way that the homeless shelters work in Franklin County is through a hotline. And if you're kicked out of one shelter, that ban more or less kind of goes into effect for all the other shelters that are part of that system. Now that doesn't include every shelter, but that is a good majority of them. So then it's like, okay, well, where do I go? And our shelters are more than overpacked. The overflow is constant, and there just aren't enough resources to keep up with it. So I mean, the barriers are just like there are programs, but it's not enough for what the need is. And also an issue with how they are accessed. Most of the programs, you cannot do self-referrals, right? Someone needs a case manager to do a referral for programming, which then means that someone has to try to get into case management, has to try to hope that that person has time and stays at the program, because unfortunately, the turnover rate is high in a lot of our programs. So that just is a huge barrier too. So there's a lot of things. I feel like I could go on, and I think a lot of us kind of experience that same stuff. I came from direct client services for a decade and switched onto this side of things. So it is interesting to kind of, I think in our role, trying to kind of take the barriers that we see, working with clients, and how can we make our programming to try to combat some of that. So I'll stop rambling.
No, we love to hear from you. And it looks like Christina in Miami, that they're having the same issues there. Quick show of hands if people know how to do that on Zoom, but would you mind raising your hand if that is a similar barrier for you in your jurisdiction? Just curious. All right. Yeah, so definitely going back to that requirements piece. That alone is huge. Sometimes it feels like programs who are providing these services, it's like for people who are already stable in a sense, where that's really not what these services are for. So how do we get past that? What systems level changes can we make or influence in order to better serve our communities? We have just a couple of minutes left. So I'd love if we could hear from one more person. All right. Oh, I see comment. Also competing with general population of people needing housing. Absolutely. I think we've all heard, especially these past few years. It doesn't really matter where we are, housing is an issue, from big cities to rural communities to suburbs. It's East Coast, West Coast, North, South. It's really everywhere, it seems like. So that absolutely resonates with me. Alyssa, I see you're off
I just
mute.
wanted to add, sorry, so
Yeah.
kind of with that general population, one of the things that I've seen some programs struggle with too is when it comes to the prevention side for housing, is so the individual does not have to be living with HIV then, obviously to access those services, but then it's who is accessing the services. And so they're having a hard time, like, okay, who our priority population is that we're trying to provide services for, but and not putting in, still trying to keep it low barrier. So not trying to put too many restrictions right on who can access it, but then sometimes having a hard time making sure that the priority population is still being reached. And while at the end of the day, if someone is getting services, that's great, but they might not be in that priority population they were trying to serve. So then it kind of gets tricky for them on, how do we draw lines? How do we, without creating more barriers for people? So on the prevention side, I know it's been difficult. We've heard from folks and trying to figure out how we can, still trying to figure out honestly how to kind of go about that in an equitable way, ethical way, all that.
Absolutely. Yeah, I think it's a line to walk. Sometimes it feels like a balancing act. We are getting close to our time though, and I want to be respectful of everyone's time. So if we can move to the next slide, please. As I'm sure many of you are aware, we at NASDAQ love our evaluations. We really we look at every single one of these. We want to know what worked, what didn't work, where could we improve, how can we continue to improve these calls and webinars to really meet your needs and make sure that it's a useful use of your time. So my colleague Sarah should be dropping the link in the chat as well for you all to click on, or there's the QR code. But again, this really, this is important to us. It doesn't just live, on a page. We actually read through every single one and look at it and make changes. So if you could complete that for us, we would really, really appreciate it. And if y'all could just give me 5 seconds, I should get that
I got
listed
it.
for
Allison.
you. Thank you so much, Zoe. And as always, we at NASDAQ, we are still a TA provider. We are here to support you on the great work that you're doing. If there's anything we could help with or support with, or any technical assistance needs, please don't hesitate to reach out to us. You can reach us here at eheskip@nasdaq.org. I'm very excited. We have our part 3 of this call series next week. I believe it's Tuesday the 19th, where the call topic is going to be focused on engaging between state and local health departments and looking at that collaboration. So we hope you can join us for that. We will be recording it and sharing it out as well if you can't make it. Thank you again for joining us today, for spending this hour with us. I really enjoyed it. I hope you did as well. If there's any questions, please feel free to let us know. And I'm going to pass it back to Zoe to see if you have any closing remarks for us.
No, that's all. Thank you so much. And thank you again to Sarah for presenting today. We really appreciate your time. And yeah, next week's office hours will be hosted by Allison and Sarah Palmer. So definitely check that one out. It'll be really interesting. Thank you all. Thanks for your time.
All right. Thanks, everyone. Take care of yourselves. Have a great rest of your week, and we hope to see you next week.